The next concept I want us to take a look at is that about shock. Now, we can define shock as an inadequate blood supply to the vital organs, particularly the brain, the heart, and the kidneys. Some people simply define it as a decrease in circulating volume. Now, in order to have an adequate circulating volume, you need to have three things. You need to have a heart that works to pump the blood around. You need to have adequate blood volume. And you need to have enough peripheral resistance to keep the blood in the proper place, to keep the blood flowing to the central circulation. If you have any problem with any one of these three, the patient can go into shock. It's important for us to know what the cause of shock is, because the management includes some differences depending on the cause of shock. For instance, if your patient is in cardiogenic shock, do you think that you should give the patient a transfusion? No. If they can't pump the blood they have, if you gave them a transfusion, it would make them sicker. So for cardiogenic shock, we need to give drugs that are going to make the heart beat more effectively. Now, if your patient was in hypovolemic shock, which means that there's not enough circulating volume. So in hypovolemic shock, this might be a patient who's hemorrhaging. Would they benefit from a transfusion? Yes, they would definitely benefit from a transfusion because they don't have an adequate circulating volume. They don't have enough blood in the body to circulate. Now suppose that your patient was in neurogenic or vasogenic or septic anaphylactic shock. The problem in these types of shock is that there is not enough peripheral resistance. You need to have enough peripheral resistance to keep the blood vessels constricted, to keep the blood flowing to the brain, the heart, and the kidneys. And in these kinds of conditions, there's peripheral vasodilation. These patients need vasoconstrictors. They need a drug like epinephrine or adrenaline to cause the increased peripheral vasoconstriction, shunning the blood supply to the brain, the heart, and the kidneys. So you can see then that it's important to recognize the causes of shock, because that will make the treatment of shock different. There are some things that are consistent for people in shock. And they might well ask you questions on the exam about the symptoms and manifestations of shock. So the pulse pressure decreases along with the blood pressure and urine output. So now the patient's blood pressure is 120/70, and they have a pulse of 80. So what is the pulse pressure? The pulse pressure is 50. Pulse pressure is systolic minus diastolic pressure. So I told you it was 120/70, and that's 50. You don't need to know the pulse to determine pulse pressure. That's a distractor. The pulse pressure is systolic minus diastolic. So if we start out with a pulse pressure of 50, and an hour later, their blood pressure is now 110/70. It's gone down to 40. And a few minutes later, it's 100/70. We now have a pulse pressure of 30. And the next thing you know, it's 90/70. That's a pulse pressure of 20. This patient's in big trouble. They're heading into shock. Usually the systolic drops faster than the diastolic. Now, urine output will go down. Easiest way to remember that is when the circulating volume is compromised, you don't have enough blood flowing to your kidney and you don't make urine output. So the urine output will decrease. In addition, when you go into shock, then you get all the hormones that say, come on, hold on to urine, because we're trying to make more blood volume. Now, pulse and respirations go up in an attempt to compensate it for the decrease in circulating volume. So you get a rapid, weak, thready pulse, which is typical of a patient in shock. And they're apt to have tachypnea or rapid respirations. Now let's talk about positioning for patients in shock. When we talked about positioning, we talked about Trendelenburg and modified Trendelenburg. And here you see a picture of Trendelenburg. This is a true Trendelenburg position, where you see the patient's head lower than their feet. The problem with this is that all these abdominal organs up here can press on the diaphragm and interfere with respiration. So this can compromise respiration. That's why it's not the preferred position for a patient in shock. The preferred position is the modified Trendelenburg position, in which the legs are elevated but the trunk is flat. This position increases venous return without compromising breathing. Now, I'm not going to sit here and tell you that you'll never see Trendelenburg used for shock anymore, because you might, and it might be the only thing you can do and the only way you can position the patient. If it is, you do it. But if I had to choose on an exam item between modified Trendelenburg and true Trendelenburg for shock, I would choose modified Trendelenburg, because that's the most appropriate one if we can do it. Let's look at a question related to shock. The nurse is caring for a client who is being treated for shock. The family asks why the client has an indwelling catheter. The best response for the nurse to make is based on which concept? 1. An indwelling catheter will help to keep urine output adequate. 2. A person in shock frequently has difficulty voiding. The catheter makes it easier to void. 3. An indwelling catheter helps prevent kidney damage, which is common in people in shock. And 4. Monitoring urine output helps to assess the person's response to treatment for shock. If we look at those questions, the best answer has got to be number 4. That's what the purpose of the catheter is so you can monitor urine output and know how the patient is responding. And because we'll want to get hourly urine outputs in this patient. Catheters don't make it easier to void, and catheters don't increase your urine output. Catheters make it easier to measure the urine output. Let's look at one more question. The nurse is caring for a person who was in an automobile accident. The blood pressure is dropping rapidly. Before placing the person in Trendelenburg position, what should the nurse assess the client for? Number 1, long bone fractures. Number 2, head injury. Number 3, air embolus. And number 4, thrombophlebitis. If you chose answer number 2, congratulations, that is the correct answer. You don't put someone with a head injury upside down. That would increase their intracranial pressure and make them worse. So you would need to make sure they don't have a head injury before you put someone in a Trendelenburg position.